So we are discussing agonist antagonist agents we used in different purpose. First we have discussed pentazocine. Next commonly used agonist antagonist is butorphanol. It is once again a kappa analgesic and more potent than pentazocine. Side effects are similar to pentazocine, that means it also causes sympathetic stimulation, and though the advantage is that it causes less dysphoria. Psychomimetic effects are that's why less marked, and as it is a kappa analgesic, it causes dysphoria, so abuse potential is low. So that means patient do not have the urge to take it repeatedly. And it is a very weak interaction of mu receptor used in postoperative and other short-lasting painful conditions like renal colic. And as it is a sympathetic stimulator, so it increases the cardiac oxygen demand, so it should be avoided in patients with cardiac ischemia. Buprenorphine. It is the longest acting opioid. It is synthetic, thebane congener, highly lipid soluble, and 25 times more potent than the morphine. So buprenorphine is 25 times more potent than the morphine. What is the more potent than buprenorphine? That is fentanyl. Fentanyl is 80 to 100 times more potent than the morphine. So buprenorphine has slower onset of action and the longest duration of action, 6 to 8 hours. And with repeated use, duration of action reaches to 24 hours. So it is actually, with chronic use, it is the longest acting opioid. And postural hypotension is prominent, respiratory depression is also prominent, and it exhibits ceiling effect. Lower degree of tolerance and psychological dependence happens with buprenorphine. So buprenorphine, it is a very long-acting drug, tightly bound to the tissue as well as receptor, and naloxone only partially reverses buprenorphine effects and does not precipitate its withdrawal. So due to its tight tissue binding as well as receptor binding, naloxone partially reverses buprenorphine effects and does not precipitate its withdrawal. Indicated for the long-lasting painful conditions like cancer pain, and it causes neonatal respiratory depression, so not preferred during labor. And another reason is that if respiratory depression occurs in the neonate, it cannot be effectively reversed by naloxone. So normally respiratory depression due to other opioids like morphine can be reversed by naloxone, but as buprenorphine effect cannot be reversed by naloxone due to its tight receptor as well as tissue binding, longer acting, and that's why naloxone cannot reverse the respiratory depression caused by buprenorphine, so it should be avoided during labor. Next, like other CNS depression, opioids also exhibit some tolerance, dependence, and it has some addiction liability. So tolerance, high degree of tolerance can be developed on repeated use. Tolerance means to achieve the same effect, we can have to increase the dose gradually, or with the continuation of the same dose, the effect gradually decreases. So tolerance is exhibited by all effect, not for meiosis and constipation. And this tolerance is mainly pharmacodynamic at the cellular level, or maybe partly pharmacokinetic, enhanced metabolism. And it is exhibited to most actions but not to constipating and meiotic actions. It shows also cross tolerance, that means tolerance to one agent like morphine means patient will show tolerance to other opioid also, and tolerance subjects are partially cross tolerant to other CNS depressant as well. That means if patient is already on some other CNS depressant, he or she is given morphine or other opioids, then he or she may require higher dose because of this cross tolerance. That means an alcoholic patient, if he is given morphine, the dose which is producing analgesia in normal subjects, for alcoholic the dose requirement for producing analgesia will be higher because of this cross tolerance. So remember, opioids show cross tolerance with other CNS depressant as well as between themselves. Dependence, a definition, is a state of adaptation manifested by receptor drug specific withdrawal syndrome produced by cessation or drug exposure or administration of antagonists. What does it mean? That means dependence means there is an adaptation at the physiological or psychological level, and this dependence is proved by sudden cessation of the drug. Patient was on using the drug chronically, but if it is suddenly discontinued, then it shows some withdrawal features. Then it confirms dependence, and this withdrawal can be artificially created by sudden administration of some antagonist. Here we can give naloxone. So withdrawal is manifested by accelerated appearance of an enhanced sign of cellular activation. So what are the mechanism? Increased RNA cyclase activation in the CNS, release of the accelerated amino acid and cytokines, activation of the microglia astrocytes, and initiation of the apoptosis process. So these are the four mechanisms by which dependence due to morphine is caused. And with what are the feature of the withdrawal symptom? It is very commonly asked Viva question. So if you remember the toxicity feature or the normal physiological pharmacological features, withdrawal symptom will show opposite effects. So there is significant somatomotor and autonomic outflow. There is agitation, opposite of sedation. Hyperalgesia, opposite of analgesia. There is hyperthermia, opposite of hypothermia, that is caused by morphine. Hypertension, opposite of hypotension, caused by morphine due to vasomotor center depression. Diarrhea, opposite of constipation, as done by the mu opioid receptor agonist. Pupillary dilation, as opposite of meiosis, caused by opioid receptor activation. So agitation, hyperalgesia, hyperthermia, pupillary dilation, diarrhea, hypertension. These are the common features of the opioid withdrawal. And there is release of virtually all pituitary as well as adrenomedullary hormones. There are some affective symptoms like dysphoria, anxiety, and depression. And it is a very highly aversive in nature, and it actually motivates the drug recipient to make robust efforts to avoid the withdrawal state. So once it is suddenly discontinued or once a antagonist is given, patient tries robustly to intake the drug again to avoid the withdrawal state, because treatment of this withdrawal is, once again, we have to give some opioid or other CNS depressant. And if patient is all dependence and if it is gradually increased, then addiction happens. So addiction is a behavioral pattern characterized by the compulsive use of a drug and overwhelming involvement with its procurement and use, in spite of the physical, emotional, or societal damage suffered by the drug seeker. So despite knowing its damaging effect, physical, emotional, societal damage, patient procures it at any cost, that is addiction. These positive rewarding effects of opiates are actually responsible for the driving component for initiating the recreational use of opiates. So mechanism tolerance dependence, I am not going into detail. So there can be defect in the receptor disposition. Agonists that rapidly internalize opiate receptors also rapidly desensitize signaling. This desensitization would be at least partially reset by recycling of the deactivated opioid receptors. The lack of desensitization caused by morphine may result in prolonged receptor signaling, and that leads to further downstream signaling cellular adaptation that increase the tolerance development. So there is lack of desensitization caused by morphine, and that results in prolonged receptor signaling, and this leads to downstream cellular adaptation that leads to tolerance development. You do not require it in detail. There can be adaptation of the intracellular signaling mechanisms. There can be inhibition of the adrenal cyclase, activation of the inward rectifying potassium channel, inhibition of the calcium current, and inhibition of the terminal release of the transmitters, which are responsible for the analgesic action. And there can be systemic level counter adaptation and activation of the protein kinase C, activation of the local glutamate receptors of the NMDA type. So these are the cellular mechanism of tolerance development. Now, more important to know is how to treat the treatment of dependence. So withdrawal of morphine and substitution of oral methadone followed by gradual withdrawal of the methadone is the principle. So I have mentioned that methadone is used in treatment of the opioid addiction or dependence. What is the purpose of methadone? Methadone is long-acting drug. It is orally effective. So once a patient is given methadone, it occupies the receptor for a long time, and even if the drug abuser intakes morphine or heroin cannot bind to the receptor which are already occupied by methadone. That's why morphine or heroin cannot produce that kick or euphoria. That's why patient feels less urge to procure the drug again, and thus methadone helps to avoid the urge, decrease the urge of the repeated morphine or heroin intake. But as methadone is once again it's opioid, we should gradually withdraw it, and withdrawal is done by giving some opioid antagonist. And here we give naltrexone. So treatment of dependence is gradually we have to give oral methadone in high dose, followed by gradual withdrawal of the methadone and give some opioid antagonist like naltrexone to avoid the adverse effect of methadone also, because methadone is an opioid and it will show all the adverse effects of the morphine like respiratory depression, and vasomotor center depression, hypotension, etc. in long term. So, however, relapse rate among prostate addicts is high. So, to remember this use of the methadone. So, and now pure opioid antagonist. We have to discuss it. It's a very important question for the Viva as well as theory. So, naloxone, it is competitive antagonist on all type of opioid receptor, but specifically acts on the mu receptor mainly. It is antagonistic on kappa and delta receptor also, but activity is mainly exerted on the mu receptor and blocks mu receptor at much lower doses. Beta-phenyltretsamine is the selective mu receptor antagonist. Norbyl-naltrexone is a selective kappa receptor antagonist, and selective delta receptor antagonist is naltrexone. So there are some selective receptor antagonists, but naloxone is competitive antagonist of all types of opioid receptors, but mainly mu. It blocks mu receptor at much lower dose, and there is no psychological or physical dependence or abstinence syndrome. And dose 0.4 to 0.8 milligram, it promptly antagonizes the all action of the morphine. And it also antagonizes in higher dose other effects agonistic action on the nalorphine pentazocine. Dysphoric, so pentazocine is a kappa analgesic, kappa agonist plus mu antagonist, but so in higher case of for to antagonize kappa, it has to be given in higher dose than the to antagonize mu receptor. Dysphoric and psychotomimetic effects are incompletely suppressed. Actions of buprenorphine are prevented but not effectively reversed by naloxone. So remember, naloxone cannot reverse totally the actions of the buprenorphine, the dysphoric action of the pentazocine, as well as tramadol action also cannot be completely reversed by the naloxone, because tramadol has some additional action, that prevention of the NE and 5-HT reuptake, which is responsible for analgesic purpose. But that NE and 5-HT reuptake is independent of mu receptor action. That's why naloxone cannot reverse the toxicity of the tramadol, tapentadol, etc. also. And it fails to displace buprenorphine that has already bound to the opioid receptors. Okay. It also blocks the actions of the endogenous opioid peptides and doesn't produce hyperalgesia, and it precipitates withdrawal in addicts. So naloxone is an antagonist. That's why patient who is on addicted to or who are addicted to morphine or heroin, it precipitates withdrawal, and it has to be given in IV route. Onset of action is within 2 to 3 minutes, and high fast metabolism in liver. Injected IV, it acts in 2 to 3 minutes. T-half is 1 hour in adults and 3 hours in newborn. So what are the uses of naloxone? Very important to know. It is the drug of choice of acute morphine poisoning. We have already known that 0.4 to 0.8 milligram IV every 2 to 3 minutes. Maximum we can give up to 10 milligram. Reversing neonatal asphyxia or neonatal apnea due to opioid use during labor. 10 microgram per kg, and it has to be injected into the umbilical cord. But remember, this opioid must not be buprenorphine. Buprenorphine induced neonatal asphyxia or apnea cannot be reversed by the morphine, naloxone. To reverse respiratory depression due to intraoperative use of opioids, naloxone is drug of choice. Diagnosis of opioid dependence. So often, who are the patients who are taking the morphine or heroin illegally, the illicit drug users, they do not agree whether drug history is asked for. He or she does not agree whether he is taking the drug or not. But if we give naloxone, if our suspicion is high, if naloxone is given, suddenly you will see that the patient is exhibiting the withdrawal symptoms of more opioid. Then it confirms that patient was actually on the drugs of opioid, and he was actually suppressing the truth. So diagnosis of opioid dependence, because it is an antagonist, it precipitates withdrawal in dependent subjects, and it partially reverses alcohol intoxication. Naltrexone. It is chemically related to naloxone, but it is a pure opioid antagonist and more potent than the naloxone. It is orally active, longer duration of action, 1 to 2 days, also slower onset of action, and it is mainly used for, due to its slower onset of action and longer duration of action, it is mainly used in treatment of the addiction. At 50 mg per day, maybe once or twice daily, no subjective effects are produced after opioid intake. So and it can be also be used in treatment of alcohol addiction also. So naltrexone, when you should use it, not initially in the addict. In the addict, we should first use the methadone to block the opioid receptor and to avoid the pleasurable effect. And when patient is stopping opioid intake or morphine or heroin intake, he is only on methadone, then methadone should be gradually withdrawn by naltrexone. We give naltrexone continuously to prevent the adverse effect of the methadone. So high dose can cause hepatotoxicity. So remember this, naloxone is the drug of choice for the opioid poisoning. Naltrexone is the drug of choice for opioid addiction. It is not used vice versa. Naltrexone cannot be used in opioid poisoning because it's slower onset of action. It should be given orally, which is not possible in the acute poisoning cases. And naloxone is also not given in the addicts, because naloxone given in the addicts will precipitate severe withdrawal symptom, because it is very short acting, and it precipitates withdrawal symptom. That means to treat withdrawal symptoms you have to give some other CNS depressant. So that's why it is problematic to use naloxone in the addiction treatment. So naloxone is used in treatment of the poisoning, naltrexone is used in treatment of the opioid addiction. Make it clear. And now next, the last part of our discussion, endogenous opioid peptides. A number of peptides having morphine-like action were isolated from the mammalian brain, pituitary, spinal cord, and GI tract, and their action is also blocked by naloxone. They are bind with the high affinity to the opioid receptor, and there are three distinct families of opioid peptides. Each is derived from a specific large precursor polypeptide. So endorphin is the most important. It is a primarily mu agonist, but also has delta action, and is derived from the pro-opiomelanocortin, POMC. So when there is stressful condition, endorphin is released, which is actually gives us some relief from that stress. So endorphins are released, especially during the exercise. Also, it is released, which we will have some pleasure, due to which after exercise which we feel good. That is the endorphin level. Due after stress or exercise, endorphin is released to make us calm. And so it is an endogenous opioid. Its action is also blocked by the naloxone. Enkephalin, there are two types, methionine and leucine enkephalin. They are pentapeptides derived from the proenkephalin. While methionine enkephalin has equal affinity for mu and delta, leuenkephalin prefers delta receptors. And enkephalin, what is the clinical significance? I have mentioned that resicadotril is a drug which is used as antidiarrheal agent. Resicadotril is an enkephalinase inhibitor, so it increases the enkephalin level, and increase enkephalin level by acting on this delta receptor, they decrease the GI secretions, and that's why it can be used in treatment of secretory diarrhea. And dynorphin, it is actually kappa agonist derived from the prodinorphin, more potent on the kappa receptor but also activate mu and delta receptors. So endogenous opioids present in our body, it actually controls the stress and other painful it actually prepares comes the patient comes us when there is apprehension or painful situation happens in our body, any painful stimuli is carried to our brain. So it is an endogenous opioid, tries to calm our patient and tries to produce some analgesic effect. And this is an novel opioid peptide, nociceptin orphanin FQ. It is also isolated from the mammalian brain, localized in the cortex, hippocampus, and some spinal cord, and play a role in stress response, reward and reinforcing action, learning and memory. So this NOFQ receptor is called opioid receptor like 1. It is called also fourth opioid receptor to be identified. So it is, in short, it is called ORL1, opioid receptor like 1. It is the fourth opioid receptor to be identified. It plays both opioid-like as well as antagonistic role depending on the site and basal site of the pain. So NOFQ, it is also an opioid, endogenous opioid, and its receptor is ORL1, opioid receptor like 1. So far we have discussed uses of opioids, specific use of the pentazocine, pethidine, buprenorphine, what are the contraindications of opioid, what is the treatment of opioid poisoning, what is the treatment of opioid addiction, what is the use of naloxone, what is the use of naltrexone. So answer a few of the questions. So number 1, Naloxone. What is the specific use of naloxone? Number 2, what is the specific use of naltrexone? Number 3, which opioid's action cannot be reversed by naloxone completely? Number 3, which opioid's action cannot be reversed by naloxone completely? Number 4, why morphine is contraindicated in head injury? Answer it in brief 3 points to be written. Why morphine is contraindicated in head injury? Number 5, why morphine is drug of choice in left ventricular failure? Number 5, why morphine is drug of choice in left ventricular failure? Okay, answer this. So this is the guideline for opioid dosing, WHO analgesic letter. So in mild to moderate pain, it is advised to use non-opioid agent plus minus adjuvant agent. We can use acetaminophen or paracetamol or an NSAID. In mild to moderate pain, not controlled after step 1, we can then add opioid, short-acting opioid as required, plus minus non-opioid around the clock agent or adjuvant. So here we can use morphine, oxycodone, hydromorphone, or plus minus some NSAID. And moderate to severe pain, which is uncontrolled after step 2, then it is advised to add NSAID as well as opioid plus some adjuvant agent. So mild to moderate pain, don't use opioid. Step 2, mild to moderate pain or pain uncontrolled after step 1, we can use short acting opioid plus minus NSAID, and step 3 we have to use NSAID plus opioids. And we can use short acting opioid, but if short acting opioid is not effective, then we can use sustained release code opioid or transdermal fentanyl patch. So this is the end of the session of opioid. Thank you.